Hi, my name is Tara McElwain. I am a clinical pharmacist at Millennium Collaborative Care. Today we will review pharmacotherapy for adults with asthma and COPD. I will cover pharmacotherapy for adults with asthma. The pharmacotherapy options for long-term treatment of asthma fall into three main categories, including relievers or rescue medications. These are provided to all patients for as-needed relief of breakthrough symptoms, including during exacerbations. Controllers, which are used for regular maintenance treatment. They reduce airway inflammation, control symptoms, and decrease future risk of exacerbations and decline in lung function. And add-on therapies for patients with severe asthma. These are considered when patients have persistent symptoms and/or exacerbations despite optimized treatment with high-dose controller meds and treatment of modifiable risk factors like smoking or food allergies. Relievers or short-acting beta agonists, also known as SABAs, will be discussed in the COPD medication section. And patients with severe asthma are referred to a specialist for add-on therapy. So in this section, we will focus on controller treatments, including inhaled corticosteroids, combination therapy of inhaled corticosteroids with long-acting beta agonists, also known as ICS-LABA, and leukotriene modifying agents. The first class I will discuss are the inhaled corticosteroids. They work by inhibiting the inflammatory response. They block late phase reaction to the allergen, reduce airway hyperresponsiveness, and are the most potent and effective anti-inflammatory medications available. They are first-line therapy for persistent and long-term control of asthma and are not indicated for the relief of acute bronchospasm. Treatment with low-dose ICS is highly effective in reducing asthma symptoms and reducing the risk of asthma-related exacerbations, hospitalization, and death. Prolonged use of high doses are associated with increased risk of side effects. The more common side effects seen with this class is oral thrush, dysphonia or difficulty speaking, hoarseness, cough, headache, upper respiratory tract infections, and increased risk of fractures and pneumonia with high doses and long-term use. With this class, patients should be monitored for SABA use, symptom frequency, peak flow, PFTs, signs and symptoms of adrenal insufficiency, especially with high doses for a prolonged period of time, signs and symptoms of oral thrush, bone mineral density, and glaucoma or cataracts. To decrease fracture risk, recommendations can include smoking cessation, exercise, using the lowest effective steroid dose, calcium and vitamin D supplementation, and obtaining regular bone density screenings. Patients should also be reminded to rinse their mouth and throat with warm water and spit out to prevent thrush from developing. Here's a list of medications within the ICS class. They are listed by brand and generic names. They include Qvar or beclomethasone, Pulmicort Flexhaler or budesonide, Elvesco ciclizumab, Arnuity ellipta, Armon Air Respiclic, Flovent Discus, and Flovent HFA. All contain fluticasone except Arnuity, which has a different fluticasone formulation with higher binding affinity to the receptor. And there's also Asmodex Twisthailer and Asmodex HFA, which contains mometasone. Here you will find a chart that lists each medication previously discussed, low, medium, high, and typical dosing, which is usually twice a day for ICS, as well as dosage form being either a metered dose inhaler or dry powder inhaler. Metered dose inhalers or MDIs use a chemical propellant HFA to push medication out of the inhaler. They require a slow and deep breath in from the device. Most but not all MDIs need to be shaken before use, and they can be used with a spacer device. Dry powder inhalers or DPIs do not contain propellants, so they require a quick and forceful breath in from the device. In clinical practice, the choice of medication, device, and dose should be based on assessment of symptom control, risk factors, patient preference, and practical issues such as cost, ability to use device, and frequency. Once good symptom control has been maintained for 3 months, ICS dose reduction should be considered and titrated to the lowest effective dose that will maintain symptom control and minimize exacerbation risk when taken regularly. For patients with persistent symptoms and/or exacerbations, despite low-dose ICS, Consider step up after checking for common problems such as inhaler technique, adherence, persistent allergen exposure, and comorbidities. The preferred step-up treatment is combined inhaled corticosteroids with long-acting beta agonists or ICS/LABA. This class works by inhibiting the inflammatory response and binding to the beta-2 receptor, causing smooth muscle relaxation and bronchodilation. More common side effects of LABAs include headache, tremor, lightheadedness, cough, palpitations, and hyperglycemia. There is a black box warning for LABAs. LABAs should not be used without ICS or inhaled corticosteroids in asthma patients due to increased risk of asthma-related death. Patients should be monitored for SABA use, symptom frequency, peak flow, pulmonary function tests, blood pressure, heart rate, and blood glucose. And in select patients, potassium. Again, patients should be assessed at regular intervals, and once asthma control is achieved and maintained, step-down therapy should be considered without loss of asthma control. Medications within this class include Symbicort or budesonide formoterol, Advair Discus, Advair HFA, and Airdual Respaclip or fluticasone salmeterol, Breo Ellipta, fluticasone flanerol, and Dulera, mometasone formoterol. This slide includes another chart for your reference that lists the medications within the ICS/LABA class, the dosage form, and typical dosing. Most ICS/LABA dosing is twice a day, except for Breo, which is dosed once daily. The last category of medications that I will discuss are the leukotriene modifying agents. These are alternative agents, but are less effective than ICS. However, can be considered on an individual basis, for example, if a patient refuses to use or has a contraindication to ICS, or if the patient also has allergies. So the first class within this category are the leukotriene receptor antagonists, which include Singulair or montelukast and Accolade zafirlukast. They are selective leukotriene receptor antagonists and cause bronchodilation. The other class is the 5-lipoxygenase inhibitors. There's only one drug in this class, which is Zyflo, which also comes in a controlled release formulation, Zyflo-CR, and the generic name is Xylutin. This medication inhibits leukotriene formation. All agents in this category help decrease airway edema, bronchoconstriction, and inflammation. Drug interactions are also listed here. For Singulair, gemfibrozole may increase its levels. For Accolade, it's a substrate of 2C9 and may increase levels of theophylline, warfarin, and 2C9 substrates. Its level may be decreased by erythromycin, theophylline, and food. Zyflo may increase levels of pimozide, propranolol, theophylline, tizanidine, and warfarin. And loxapine inhalation should be avoided with all three leukotriene modifying agents. This chart lists each medication, typical dosing, common side effects, and clinical pearls. Singulair is dosed 10 milligrams once a day in the evening. Accolade is dosed 20 milligrams twice a day, and it should be taken on an empty stomach 1 hour before, 2 hours after meals. Zyflo immediate release is dosed 600 milligrams 4 times a day. An extended release formulation is dosed 1200 milligrams twice a day. The ER tablet should be taken within 1 hour after meals and should be swallowed whole without breaking the tablet. Common side effects as a category are headache, dizziness, abdominal pain, upset stomach, increase in LFTs, upper respiratory tract infections, pharyngitis, and sinusitis. LFT should be monitored with both Accolade and Zyflo due to contraindications in patients with hepatic impairment and/or active liver disease. With Zyflo, LFT should be monitored more frequently at baseline, every month for the first 3 months, and 2 to 3 months, and every 2 to 3 months for the rest of the first year, then periodically. SABA use should also be monitored with all agents. Additionally, patients should be monitored for neuropsychiatric events such as signs of aggressive behavior, hostility, agitation, depression, and suicidal thinking. Lastly, in rare cases, patients present with systemic eosinophilia, sometimes presenting with clinical features of vasculitis consistent with Churg-Strauss syndrome. So that pretty much wraps up the asthma medication. So we'll go on to COPD pharmacotherapy now.
Hi everyone, my name is Azra Mustafa. I'm a pharmacist here at Millennium Climate Care. As Sarah mentioned, we're going to take a deeper dive into the COPD medications. The first class that we're going to be talking about is the short-acting beta-2 agonists, which I will refer to as SABA. Medications within the class include albuterol and levoalbuterol. Their mechanism of action is these agents bind to the beta-2 receptors, causing relaxation of the bronchial smooth muscle, which leads to bronchodilation. They work within about 3 to 5 minutes, and they last about 4 to 6 hours. They're typically prescribed as needed to allow for urgent relief. SABAs are the drugs of choice for exercise-induced bronchospasm. High doses of SABA as needed in patients already treated with LABAs is not supported by evidence. Escalating doses have not shown clinical benefit. Some of the side effects are cardiac arrhythmias and hypokalemia, and it's really dose related, so as the dose increases, the side effects increase. Our next class is the long-acting beta-2 agonist. These relax the airway smooth muscle for a longer duration compared to the SABAs. They are used for maintenance therapies where SABAs are used as needed. The LABAs can be either taken twice a day, and now we have new therapies that can be dosed once daily. Our 12-hour formulations include formoterol or Fordil, salmeterol, the Ceravent Discus, and aformeterol, which is the Brovana. Our 24-hour formulations, which are dosed once daily, is the indacaterol or Aircapta, olodaterol, which is the Stravati Respimat. There are several studies showing that the long-acting medications are actually more beneficial than the repetitive use of the short-acting agents. LABAs have shown to improve health status, quality of life, and FEV1, and have also shown to decrease COPD exacerbation rates. Monotherapy with LABAs is actually contraindicated in the treatment of asthma. LABAs increase the risk of asthma-related death and should only be used in asthma patients who are currently receiving but are not adequately controlled on long-term asthma controller medication like an inhaled corticosteroid. Common side effects seen with the LABAs include palpitations, headache, and tremor, which may limit a dose increase in some patients. Next, we have the anticholinergics. They inhibit the muscarinic cholinergic receptors and reduce the intrinsic vagal tone of the airway, which leads to bronchodilation. We have both the short-acting and the long-acting. Short-acting, which I'll refer to as SAMAs, include the apratropium bromide, which is Atrovent. It has a rapid onset and lasts about 6 to 8 hours. Next, we have the long-acting anticholinergics, which I will refer to as LAMA. Until more recently, tiotropium or Spiriva was the only LAMA available, but now we have plenty to choose from, some dosed daily and some dosed twice a day. So our 12-hour formulation is aclidinium or Tuzora, or glycopyrrolate, and it's also known as Zebra. Our 24-hour formulation, which is dosed once a day, is the tiotropium Spiriva, and the other one is the umclidinium, which is the Incruz. Side effects are generally similar between the short and long-acting. It includes dry mouth, so you can counsel the patients to rinse their mouth after inhalation to reduce any dry mouth side effects. Bitter, metallic taste, nasopharyngitis, and upper respiratory tract infections. You want to use caution in patients with urinary retention or narrow angle glaucoma. Treatment with LAMAs have shown to delay first exacerbation, reduce the overall number of COPD exacerbations, related hospitalizations. They've also shown to improve health status and improve the effectiveness of pulmonary rehabilitation. Next on to the LAMA-LABA combinations. So this is some of the newer classes out there. Direct head-to-head comparisons involving LABA-LAMA combinations are required to enhance understanding of the potential benefits of one fixed-dose combination over another in patients with moderate to severe COPD. The available 4 LAMA-LABA combinations have differing frequencies and administrations. Some are dosed once a day and others twice a day. So the olodaterol tiotropium combination, also known as Thialto, is dosed once daily. The Nero-Ellipta, which includes the umclidinium vilantrol combination, is also dosed once daily. Then you have the Bevespi Aerosphere, which includes formoterol glycoprolate. That's dosed twice a day. You have the Udobron Neohaler, which includes inidactrol and glycoprolate. That's dosed twice a day. Device characteristics and inhalation techniques differ between the products. Just a quick overview of the inhaler types. So your dry powder multi-dose inhaler includes like your Press Air, your Ellipta, and your Discus inhalers. Your dry powder capsule, which have a piercing device in the inhaler, are your Neohaler and Handyhaler. Then you have your metered dose inhalers, which are your HFAs, and your soft mist inhalers, which are your Respimats. Products containing both the LABA and LAMA in one device provide a rapid onset of action that ranges from 5 to 20 minutes and bronchodilation effect that lasts from 12 to 24 hours. The long duration of action allows once or twice daily administration, which may improve treatment adherence for patients. The safety profile is characterized by a combination of side effects specific to each component. So the most common side effects reported with the combination include urinary retention, urinary tract infection, cough, pneumonia, headache, dizziness, chest pain, muscle aches, glaucoma, increased intraocular pressure, hypersensitivity, and cardiovascular events including tachycardia, palpitations, and hypertension. In studies, the incidence of these side effects range from 1 to 10%. Clinical trials comparing LABA-LAMA versus monotherapies have not demonstrated increased incidence of side effects. Several randomized clinical trials, systemic reviews, and meta-analysis have demonstrated a greater bronchodilator effect and improvements in symptoms and health-related quality of life when the LAMA-LABA combination were compared to monotherapies or placebo in patients with moderate to severe COPD not responding to a single bronchodilator, whether that be a LAMA or a LABA. Studies comparing LAMA-LABA versus LABA-ICS in patients with COPD showed improvements in the trough FEV1, lower, moderate, and/or severe exacerbation rate, reduced use of rescue medications, and lower incidence of pneumonia with the LABA-LAMA group compared to the LABA-ICS group. These consistent results have led to the inclusion of the LABA-LAMA as the preferred treatment option in patients with moderate to severe COPD not responding to monotherapy, with LABA-ICS being the alternative therapies. Now on to the newer agents out for COPD management. It's the triple therapy. Trelegy Ellipta is a combination of an inhaled corticosteroid, which is fluticasone, a long-acting muscarinic antagonist, umeclidinium, and a long-acting beta-2 agonist with vilantrol. It's delivered once a day in an Ellipta dry powder inhaler. With triple therapy, the inhaled corticosteroid reduces inflammation, helping keep the airways clear. The LAMA blocks the muscarinic receptors, which is involved in the contraction of the muscles, causing the muscles of the airways to relax. The LABA activates the beta-2 receptors in the airways. This causes the muscles of the airways to relax, helping to keep the airways open and allowing the patient to breathe more easily. There was a study that was completed that was a 52-week randomized double-blind study that included over 10,000 patients. Patients were symptomatic with a history of moderate or severe exacerbations within the previous year. Patients were randomized either to the Trelegy, the Breo Ellipta, or a narrow Ellipta. Each treatment was administered once daily in the Ellipta inhaler. It was actually shown statistically significant reduction in COPD exacerbations when compared to the Breo Ellipta and the narrow Ellipta. So we can see with the study 15% reduction in the annual rate of COPD exacerbations versus the fluticasone vilantrol combination, and a 25% reduction in the annual rate of COPD exacerbation versus the umeclidinium vilantrol combination. Both of these were statistically significant in the study. The most common side effects seen with Trelegy, which may affect about 1 in 10 people, was nasopharyngitis, headache, upper respiratory tract infection, and more serious side effects include pneumonia, which is most commonly seen because of the ICS component, which actually increases the risk of developing pneumonia. Oral thrush has also occurred in patients being treated with fluticasone, which is a component of the trilogy ellipta. So monitor patients periodically and advise the patient to rinse their mouth with water without swallowing after inhalation to reduce the risk of oral thrush. Now on to roflumilast, also known as Daliresp. It is an oral agent used for COPD. It is a phosphodiesterase 4 inhibitor that increases cyclic AMP levels, leading to a reduction in lung inflammation. In patients treated with triple therapy, which includes LAMA, LABA, and an ICS, if they're still having exacerbations, providers may add Daliresp. This may be considered in patients with an FEV1 less than 50% than predicted and chronic bronchitis, particularly if they've experienced at least one hospitalization for an exacerbation in the previous year. Daliresp has been shown to decrease moderate and severe exacerbations requiring corticosteroids by 15 to 20%. It is not a bronchodilator and it is not intended for the treatment of acute bronchospasm. You always want to use Daliresp in combination with at least one long-acting bronchodilator, whether that be a LAMA or a LABA. An initial dose of 250 micrograms once daily is recommended for the first 4 weeks of treatment in an attempt to improve tolerability. Studies show this titration has shown to reduce the rate of treatment discontinuation by 6.2% in patients compared to those receiving 500 micrograms daily at initiation. Keep in mind that the 250 microgram dose is not an effective therapeutic dose. Common side effects include nausea, reduced appetite, weight loss, abdominal pain, diarrhea, sleep disturbances, and headache. Some drug-drug interactions that are seen are with the strong CYP3A4 inhibitors and inducers. So you may see increased levels of the drug with inhibitors like erythromycin, ketoconazole, fluvoxamine, and cimetidine. You may see decreased levels of the Daliresp with your inducers like rifampin or phenobarb, carbamazepine, and phenytoin. The next few slides are just summary tables of the different medication classes and their dosing. So again, the SABAs and LABAs, your SAMAs and LAMAs, and then your combinations, your LAMA, LABA, and your triple therapy, LAMA, LABA, ICS for your reference. Again, drug name, both brand and generic, and the dosing recommendations. References, we use the GOLD guidelines, the GENO guidelines, and a tertiary resource with Lexica. Thank you so much for listening. We hope everyone enjoyed the presentation.